you are aware now, such patients are increasing in our day-to-day practice. It's wise for us to understand. And I'll just briefly take you through, in coming 10 minutes, what are the important things to be considered. This slide brings best wishes from Citizens Hospital, where we presently practice. Proud to present our team of cardiologists for Fax Professional Services, which are a team of 27 cardiologists and 3 cardiac surgeons, render services in multiple hospitals in hub and spoke model, and with a single point of delivering the world-class care to each patient irrespective of the place of presentation. So such complex procedures which need image guidance and things like that, when they present to any of these hospitals, they'll be shifted to one of those bigger centers which where they have all the facilities. So as it's told in the previous speaker, we need to prepare ourselves well before we take up such complicated procedures like CTO and other things. Coming back to the topic today, my agenda in the coming 9 minutes would be basically briefly introduce what is the incidence of this CKD along with CAD, and present you some data about what are the impact of CKD and the outcomes that we know, and how does the CTO recanalization impact in these patients of CKD, and what is actually contrast-induced echo. Briefly I will touch upon, and we'll briefly present to you a protocol to prevent such worsenings, and then touch upon this important technique of doing such procedures with Mozart, and zero contrast techniques are also described with more usage of imaging, and present to you some of these interesting cases where one of these microcatheters were used in our procedure to avoid the contrast loads, and to conclude in the end with some important points. As you see here, cardiovascular disease in patients with or without CKD, obviously we know that CKD patients have very high incidence of coronary artery disease, as high as up to 70% compared to normal population, which is about 30%. Be it any CVD or an atherosclerotic disease or acute MI, the incidence is significantly higher in CKD patients. That's how we consider CKD itself as a risk factor for CAD along with others. And if you see the survival patterns in patients who are undergone PCI, whoever had CKD, they do worse. And without CKD, we have good outcomes, but with CKD, patients do survive less. And if you see the STEMI, one of these articles showed about 1,873 patients, 18% had CKDs. When the CKD incidence was, the survival was much less when these patients had higher creatinine levels and follow-up. If you see the various incidences of CTO percentages quoted in various CKD studies, it varies a little more. Normal it is about 5%, but here it could go up to 15 to 19%. But we know very little about what to do in these such patients. So as NIC chair, when we are trying to collect our own country's data of CTI, we came to know that about 3.6% of total procedures, like roughly about 14,000 were CTO, out of which 3% out of these 391 cases were retrograde CTOs. So phenomenal work is done by our Indian colleagues, and usage of microcatheters was about 66% in these cases. And then I tried to collect about what was the incidence of CKD in that, but we couldn't get into it. And if you see the impact of CTO recanalizations, even in patients, we see if a patient has a single vessel disease, they do well. Single vessel with no CTO, they do better, and associated CTO, that worsens the prognosis. When you try to see whether they can be left alone with medical treatment, obviously the revascularization by whatever modes, they do better. MACE rate, survival, and overall survival was much better with revascularization, rather than leaving these patients who die more with medical therapy. So there is no doubt that there is a requirement for revascularization even in such high-risk patients. When they try to see what is the background in which the worsening things happen, the age more than 70 years turned out to be predominantly important risk factor to avoid doing such patients. When they try to see whether PCI or CABG, which is better in subset of patients, both of them in a CKD subset did not matter much, and any part of revascularization had same event rates and same survival. But the patients who were failed versus successful group, obviously we understand the successful group have a better outcome rather than mortality compared to failed subgroup. So we have registries coming up like quoted here, but why we tend to learn such things is, obviously we know with revascularization, patients are better quality of life and better outcomes. But on the contrary to it, what is the problem is patients of these age fragile patients, risk of worsening of CKD and going in requirement of hemodialysis is all much more, which will increase the mortality in these patients. So if you see what is the general incidence of contrast-induced AKI in these patients, it varies from 5% to 25% depending upon what is the GFR levels in these patients. If you particularly try to see in the CTO what is the incidence quoted, incidence may be wrongly reported in various studies, but it was about 5% in this. I think these Japanese colleagues give a lot of information. In the stage 1, when there is no CKD in these patients, incidence of AKI was about 4.6%. Stage 1 of CKD, it was 8.9%. As it goes to stage 2, it is about 16.7%. So we need to be more careful when the GFR values fall below 45. Then this is another thing which showed, though acute incidence has increased even in the subgroup, but the long-term requirement of dialysis was not much different. This is reassuring for us. So immediately they may require 2-3 episodes of dialysis, but long-term requirement was not good. But as the disease progresses at 5 years, about 7% of them require dialysis. So that's how we need to be careful and see our patients. One word of caution I would like to mention is, don't put all the higher creatinine values together. We now are very wiser that GFR depends a lot on the individual patient's body weight. GFR of this beautiful lady here, if it is a creatinine value of 0.8, 0.9, which could be normal, but for such high body mass index patients, the GFR of 1.4 could be also, a creatinine of 1.4 could be also normal. This week, if you were wiser, we were part of this NEPHRIC study in 2009, which we published with contrast, comparison of various contrasts, but this data is now very well aware. All of us need to be aware that we need to go with GFR values rather than creatinine. CKD versus CTO outcomes, if you see, this is an important slide, I want your attention. If you see here, if you did not succeed in producing a CTO, this is one of the groups, Chinese groups, where 89% success rate is quite good. But if they couldn't do CTO open and produce CIN, that is a contrast-induced nephropathy in these patients, hazards was much, much more. On the other hand, if you didn't do anything and left it, or also reasonable. But if it is open and no CIN, that is a red line, that's the best. But even without opening, without CIN, patients did not do much better. In other words to say, revascularization improved the outcomes, but contrast-induced AKI overrides the benefits of revascularization in CTO. So if you are not able to open up the vessel, at least don't do more harm in creating more trouble to these patients. That's the message of this study. So if you have to see which are the patients which are likely to worsen, age more than 75 years, EF of less than 40%, and creatinine more worsening points, that is, we need to be careful in those subset of patients. The algorithm, which I think each of you will have your own, these after proper calculation of GFR, IV hydration is the most important, which we need to do it, and then discuss with nephrology colleagues, and the various options of bicarbonate therapy and prophylactic other drugs have been come, but most important I would see is hydration of these patients and use limited contrast volumes. That goes a long way. And how to limit these contrast values, we're using some of these microcatheters and imaging techniques. That's what I would briefly touch upon. And there is some data coming up with renal guard, renal replacement therapy, which is useful post. This is an important landmark article, state of review paper, utilization of IVUS in chronic total occlusions. I would like you to go. And the zero contrast technique is also described basically with imaging and usage of FFR in these patients of CTOs. Intravascular ultrasound is our best friend to avoid too much of contrast. And Mozart is that minimizing contrast utilization with IVUS guidance. We use IVUS only to finally cross-check the results and outcomes. That's how they could limit the contrast usage to significantly less value without IVUS. That's what it came out. If you see the IVUS images, this cartoon shows this antegrade, retrograde wires. If they are near this lumen, they're more likely to chance of success. Rather than if they're totally away like this, then probably you would fail. So this case example, I don't know whether it will play or not. Will it play? Playing? Okay, it's good. It's not playing here. Okay, this is one of these cases. You see this, everything is very important here. Previous PCI surgery done, but LAD CTO, LV ejection fraction is normal, creatinine is less, but what we need to document very clearly is the patient should have definite angina and definite revascular ischemia. These are the subsets of patients who would have benefit most. And initially we tried to do with retrograde technique, then the wire went unfortunately into the wrong lumen there, then we again crossed the antegrade and tried to give a good result. That's the final result of LAD. Overall procedure was done in about 85 ml of contrast. This is another interesting thing which we found when we are using the Lima injections, a lot of contrast was going. So we thought we could use microcatheters take it into the Lima and inject here and see that with 3 ml of contrast, we could get reasonably good picture of retrograde filling. So that's one way to avoid some of these innovative methods to see. And then finally, IVS-guided RCA was done. The entire RCA was reconstructed well. Antegrade reconstruction always gives a better outcomes. This is another patient. I would just briefly conclude in half a minute. The 81-year-old gentleman, the patient is already on hemodialysis, then you need not worry too much. We do a good job, though it is not a this thing, but we have a very critical LCX disease there, which was initially then guideline usage, and then probably exchanged over mitral catheter. Then still the stents were not going, then we tried to rotablate and create space and then taken these places. So it's in other words to say, once you have taken these patients for the procedure, you can't do incomplete job. You try to do a proper revascularization, be it be whatever it needs. But if patients are on hemodialysis, your job is a little better. So that is actually the final result with both stents. I'll conclude in the last line. That's a result in this. That's to conclude, the patients with CTO and CKD, we know that they have worse prognosis. CTO PCI in these patients, obviously when revascularization is done properly, has better outcomes. And CKD patients often are undertreated in our day-to-day practice because of fragility and the risk of AKI. But what I would like to mention is you properly assess them, pre-treat them properly, and maybe the creatinine values could improve before we dump them as patients who cannot be done. The optimal usage of IVUS is fundamental to reduce the contrast, that is Mozart techniques. And finally, what I'd like to mention is contrast-induced AKI dominates over prognosis over the CTO recanalization. So that's how do not harm the patients first. The dictum prevails even in the CTO recanalization in CKD patients. Thank you very much.
Thank you. Thank you. Since the live transmission is waiting, we will not take any question from the floor. But before Srinivas, you, there are glomerular biomarkers for AKI, like cystatin C level, tubular biomarkers like galactine, proencapheline. And do you routinely recommend these biomarkers before doing CTO PCI?
No, basically we are talking of more sicker patients. All those things where you're using where your patients almost have a normal renal function and you are trying to see which are the patients who are trying to develop AKI. The talk here pertained because basically more of sicker patients. But the cystatin, some data is coming of cystatin, but we normally don't use it as in day-to-day clinical practice. There's a lot of interest when we are doing with NSL cysteine, we did a comparison study whether worsening could improve. But finally, various things are tried, but what we found most in clinical practice is saline, hydrating the patients well and limiting the contrast. Those two are the best. I think take-home message from the typical tip is the retrograde injections, rather than giving it from the main guide catheters, if you put a microcatheter, then give injection, lot less contrast is consumed to image vessels well. That is one of the important tip I thought I would give to everybody.
What about coronary sinus suction?
The coronary sinus suction and other things are described, but they're not practical in day-to-day practice to be used. I thought which are more relevant we will cover. Microcatheter, especially if you have double lumen catheter, which is coming up, also can be used very easily for this purpose.
Okay. Thank you.
Thank you.
We close the session, sir. Thank you.
May I thank the chairpersons and the speakers of this session. With this, we go on to a next session, which is again a live transmission. And may I request the chairpersons of the next session to please come on to the stage. Dr. Koshi Matsuo, Dr. Anil Dhal, Dr. Srinivas Reddy, Dr. C. Raghu, Dr. M. Jyotsna, Dr. A. Patnaik, Dr. Damodaran, Dr. Matthew Paul. And the expert panelists, Dr. Kanhaiya Jaswani, Dr. G. Ravikant, Dr. Ranjan Shetty, Dr. Sadanandan, Dr. Balaji, Dr. J. Keshav Murthy, Dr. Sai Sudhakar, and Dr. Rishikesh Patil. We will take you to Sunshine Hospitals, SP, SGPI, Lucknow, and Apollo Hospital, Hyderabad.
いうかパーフォレーション I think はい already come to
Yeah. Actually, who is online? I think we will start the I think the last live case sessions today. And who's there online? Can I get to Dr. Nagamatsu?
yes
Yeah. Very good afternoon.
Yeah, good afternoon.
We have a complete expert panel, including Dr. Koshi Matsud,
Madam, please.
Dr. Raghu, Dr. Jyotsna, Dr. Patnaik, Dr. Damodharan, and Dr. Paul here. And we would like you to introduce your case and tell us the case details and what's your strategy.
Okay, thank you very much for the invitation. Okay, open 8. Okay, just a moment, just a moment.
Yeah, sure, sure.
Just a moment.
Show the first slide.
Okay, down please.
First slide.
Okay, please do the case introduce first.
Yeah, go to the next.
Yes.
Yeah, I'm Dr. Sridhar Kasturi from Sunshine. Good morning to all of you.
Yeah, very good morning, everyone.
So let me introduce my team, my associate Dr. Lokesh, Anita and Venu, Chief Technician. And very pleasure to have you, sir. Dr. Nagamastu is performing the case. Actually, let me apologize for changing the case. Actually, LAD CTO was there, but he had a fever. Because of that, we are able to change the pace. Then we requested. This is a 54-year-old female patient, diabetic, and she underwent PCA 1 year ago. That is LAD and RCA. That is bromosphere was done. And recently she presented with CTO. And initially, one of my colleagues attempted a PCF CTO of LCX but couldn't perform due to dissection of the. Then they postponed. Today we are keeping this case for live transmission. Then he will explain all the rationale and everything. Go to the next.
Next slide. CT
That's it. We did the CT angio. You can show the CT angio films. Yeah, yeah. You can see the CT angio, well patent LAD stent and RCA stent. LCX CTO segment not showing any calcification. It's a fibrotic lesion and ending at a bifurcation site. And proximal portion of the LCX also significantly diseased. Yeah, you can proceed, sir.
Okay. Okay, please change the angiogram.
Yeah, show from the beginning.
From beginning.
Sir, you have a remote.
Yes, yes, I
Yeah,
can
you have it.
control. Okay, can you see the angiogram?
Yeah, we can
Okay.
visualize that.
Okay, so I forgot to introduce myself, and thank you very much. I did appreciate the invitation, so it's my very great honor for me. And so I will show today's angiogram, and this is the cranial view. And as you can see, already put a stent at the LAD, and this stent status is quite good. Yes. And we can see a little bit collateral from the diagonals. So diagonals mean the proximal diagonal and the distal diagonals seems like connected to the distal part of the circumflex. And this is other caudal view. And we can see the CTO lesion at the distal middle part of the circumflex and just branch it to the small PL branch. It looks like this type entry is abrupt type. So we cannot see the entry, and I will show that later in another angle. And another problem is that we can see the severe stenosis, almost 99% stenosis proximal part of the CTO entry. So maybe we have to fix this lesion before CTO PC procedure. And in this time we can see the AC branch, but this AC branch not too connected to the CTO distal part. Yes, usually we can see the zigzag collateral, but in this case we cannot see that. And this is apicaudal view. Yes, and we can see the collateral from the diagonals. And we call this a collateral, it's a ipsilateral collateral, but this floor is very quite poor. This is the left cranial view, and we can clearly see the both diagonals, the apicaudal channel connected to the circumflex distal part. But very unfortunately, this quarter both include very tight bending parts from many years. And the another important information is we can see the heart beating with this vessel moving. So this channel is very difficult to use for the retrograde PCI, so the ivory of the perforation very easy. And I showed the spider view. Yes, well, this view is more clearly we can see the proximal part and the region. And we have to fix this. It looks like a vessel diameter 3.0. And I showed the contralateral injection. Can you see that? So this pattern is a very rare pattern, I think. So usually the circumference, the connection is from the AB. But this patient connected from the PD. I think that there be apex, I think, very rare case. And more clearly we can see that this quarter from the left LAO 20 cranial 30. But how about this channel is an interventional or not? I think not so good channel, not interventional. Okay, so maybe that this is the final option for me. I should RLO like this. And so the previously, so we do the bilateral injection from the confirmation, the CTO length, and another information. So the actually there is no severe clarification. And the length is looks like within 20 millimeter. And this time is the first attempt. There is no severe bending part from the CT angiogram. The problem is only the ambiguous entry. So from the IJCTO score, maybe this score is only the 1. Yes. This is epicaudal like this.
So what we infer from you is that you're going to have firstly the antegrade approach.
Yes, and from the IJCTO score, and we have the chance to pass through the antegrade.
You can go for the retrograde approach from the PDA branch.
Yes, just only the last option.
Segment is short. I think you can first try the antegrade approach. I think, but the one inhibiting factor is that you have a side branch there. I think. You have to maybe you need to use a double lumen catheter or something like that.
Yes, good option. So I would like to do the IBUS guidance entry.
Yeah, IBUS guidance you can identify the penetrating cap, proximal cap.
Yes. So this type is ambiguous. So I would like to do that, and I would like to use simultaneously a double lumen microcatheter and for getting the good backup force. This is my first plan.
Any comments from the other panelists?
The anatomical challenges here are one is ambiguous
please move
cap,
spider view, please.
Yeah.
And please give me the balloon again.
cap at the bifurcation,
I would like to check the length
and
from the
the
other
distal
angle.
cap ends at bifurcation. And one more thing is before the proximal cap, the segment is so aneurysmal, almost dilated one. So whether to point the guide wire towards the proximal cap is a bit challenging. Obviously, keeping a IVAS in the side branch can help to penetrate the
Fix from here. Okay, thank you.
I think in the first instance they are going to fix up the proximal lesion. I think they have intended to fix the proximal lesion prior to the CTO cap.
Please keep.
I think Dr. Nagamatsu, while you work on your case, we will go to the other case from Lucknow. I think we welcome Dr. Dr. Werner and Dr. P.K. Gole is on live there.
All right.
Yeah, hello.
Yeah, sir, this is Dr. Reddy from PGI, and we have some expert panel here. Comprising Dr. Matsuo, Dr. Damodaran, Dr. Patnaik, Dr. Jyotsna, and Dr. Paul. So a very good morning and welcome to you, and please go ahead. And good morning to Dr. Varnatu.
Yeah, okay.
You're there online.
So Yeah, so with me is Dr. Werner, who's going to do the case. And can I just see the slides? Can I just see the slides? So actually this is a patient who's had an anterior MI 3 months back, and at that time, 57-year-old man. So I took him up and did an angiogram on him. And you are seeing this is the first shot of the angiogram. Can you show me the first shot of the angiogram? So what you saw was there is the LAD actually has a disease, severe stenosis. I'll show you in another view. And the RCA is occluded, and MI is anterior, mind you. Next frame, please. Next. So there's a big OM that is okay. The distal circumflex is occluded, and the RCA is also occluded. Next. And you, sorry, previous one, please. And you see the critical disease in the LAD. In mid-LAD, just beyond the septal, there is a critical disease. So at that stage, I thought that probably LAD is the culprit with anterior MI, and I did the LAD, and the OM was okay, the large part of it, and I thought the RCA could be done second stage, and there was collaterals to the RCA. You see the septal collaterals. So that's why this patient is now being taken up for a second stage procedure. So can we go to the current angiogram, please? If we do the fluoro, I think we'll get the current angio. We'll go back to the original one, please. Okay.
So,
yeah, now you want to talk, Doctor.
Yes,
now Dr. Varna is going to tell you what is the plan and what all he has done.
So first of all, thank you, Dr. Goel and his team, to have me here do a live case in this Center of Excellence in CTOs, also with the nice equipment. We hope to show you also some CT image that you will then comment.
Yeah, sure.
But basically the setup is that it's a typical situation. A patient comes with ACS of a non-CTO lesion, and the ACS is treated, and then we should treat, I think, the CTO of a large territory. The LV function we should mention was normal.
LV function, there is some anterior hypokinesia, and the EF large is about 42% if I'm not wrong. Yeah.
So we did not do anything. We waited for you for some time. We just have the setup. Femoral, short amplatz, 7 French to the right. Radial, 6 and 7 slender sheath.
Yeah, this is standard that we do for radial.
With EBU 3.5 to the left. I put, as you see on this shot, a wire into the distal LAD, and Dr. Goel tried to leave the stent free, but it never works.
Okay,
so
I specifically put the stent slightly beyond the septal, but there is still difficulty getting into
So we
the septal.
should see also the second plane, the B plane. They should show both.
No, it's you.
Here, yes.
Okay.
So we have the luxury of a biplane. So this is the situation. Maybe you want to make a short comment?
Yeah, we understood from your
You've
case
seen
that...
the RCA lesion.
yeah, we saw there's RCA diffuse disease and the CTO in the distal RCA. And you tried to fix the LAD, leaving
Would
the
you like to-
septal to approach for the retrograde approach.
Yes. Now the issue is, should we do antegrade or should we do retrograde? That's what I was discussing with Dr. Werner.
I think we can try.
So what do you think? We should go antegrade, we should try antegrade, or we should go retrograde?
I think maybe antegrade approach would be the first. I think if that fails, you can go for the retrograde.
Yeah, it looks to be the reasonable to try the antegrade
What
first,
is very...
because it's
It's a
even
long
though-
segment. That we understood.
and even though the multiple lesions are there, but still there is up to the mid segment of the RCA, it is looks to be then fair enough to go for the antegrade.
Yeah, but what you have to consider is, with the antegrade approach here, that it is a flush occlusion at the crux. And if you only go a little bit subintimo, you may lose one of the branches, which is not what we want. We want to save the whole system. So that is the consideration why in such a rather easy lesion, tapered and so, we should keep retrograde very first on our list.
Okay, we do agree because there are the large PDA and PLV branches and the flush cutoff just at the origin of the both.
Maybe we
Yeah.
can discuss the CT because it's also
Yeah,
important
so now
to
the other,
see.
you see what we have here, we also have CT on the side. Can you show the CT picture, please? And we trace the arteries on that, and you see the right coronary is seen, you see it in yellow color, that's the artery which is patent. And the ones which are green and purple, they have been traced by hand, trying to connect the two segments so that we have an anatomical understanding of the entire arterial tree where we are crossing the CTO segment. So this tells us very well about if there are bends inside the CTO segment or how long it is, and it can be, we can use this on the side when we are wiring the CTO, and it's quite helpful. We have a system where it can be overlaid into a live fluoro also, but we usually are not doing it right now because that produces a lot of difficulty with the eye, with the moving pictures of the live fluoro and the CT. So we see that this is about 25-30 millimeters of occlusion, if I'm not wrong. At least 30 millimeters, if not less.
So,
But the calcium somehow is not too much in this. There is not much calcium from the CT point of view. So maybe it is softer because we don't know how long the RCA is occluded. The acute event was anterior. So let us see what Dr. Werner wants to now do.
yeah.
So
That is the situation. And as we waited for some time with the patient, we want to show, we didn't want to do anything decisive without you. So show the first picture.
Yeah, move forward.
Move forward.
Yeah.
So we went with a Fielder XT and a fine cross, which is my preferred antegrade microcatheter, rather far already, probably at the proximal cap.
Yeah.
I left it there, and then we prepared the retrograde access.
Okay.
This is a Sion blue just to access the septal. You want to say? Comment?
Yeah, we are with you. Are you? Yeah. What is
So,
the
as
antegrade?
often happens,
Okay.
is that, of course, the struts overlay. So I couldn't get a Corsair through the struts, so we did dilatation with a Minitrack 1.2. And next, and then we got the Corsair through. Of course, we must remember this. At the end, we should post-dilate the stent again. Yeah? And it's important to have a safety wire down in case anything happens.
What is
And
the antegrade
next,
wire?
then I tried to do a selective shot.
Sion blue.
It's a BMW, and the Sion blue was for collateral access. This is the selective injection. And that's where we are. We haven't done anything.
So
You tell us what we should do.
Yeah, I think that's fair enough. I think you're trying to access the retrograde approach through, maybe if you can get it with the cyan blue, or then you can go up to this O3 wire if you can't do that.
yeah, because once the retrograde wire is in, then even if we just reach the distal end of the vessel, that will still help us
At least.
moving the antegrade wire forward. So I think we should probably...
So we will try now. I have the Sion, regular Sion. And I need my reference image.
Reference image, lagao.
Yeah, Dr. Goyal, I think we'll come back to you within a few minutes. I think we'll go to the other hospital. I think you keep working on with your thing. And
Okay, all right, then you can go to the other one.
yeah, we'll come back very soon.
Maybe what you just saw.
You want to see the crossing, maybe it will cross...
Yeah, if we can take just 2-3 minutes, I think
Actually,
if
we
we can please
waited
see-
for you to show the collateral
sure.
crossing.
We are with you.
So if you
Carry on.
want to, I think it's worth, if you wait for 5 minutes,
Okay.
let us be live for another 5 minutes and see if we can cross.
Yeah, sure,
because
sure,
that's
we are-
what we were
we are
waiting
online
for,
with you.
so that you can see, yeah, because,
So you are now
Okay,
with
if it
a
doesn't
regular
work
Sion.
easily, we can
You're now with a regular
Yeah, this is
Xeon
a regular
wire.
Xeon, that's correct.
Yes.
Correct, correct. The regular Xeon is that hydrophilic wire,
Okay.
so the traversing is easier with it, but sometimes the hydrophilicity also gets you into the problem of perforations. So one has to be knowing that and
So-
be careful about it.
It's difficult to get the first bend already.
Because we need to move into the anterior part,
Yes.
the front one. Maybe a little wire back. You need to move it from front.
See, Dr. Goyal, what we have learned from this IJCTO is that I think in the retrograde techniques, most of the times we are taking upfront the SO3 wires rather than trying these wires. What do you feel?
Yeah.
We don't have it.
Yeah, SO3 incidentally, I don't have it here
Okay,
right
also,
now.
Okay. Maybe I need a different bend. Take
Yeah.
out the wire. Take it out.
Yeah. So maybe a sharper bend which will get
I
you
need a
angle.
bigger bend.
Yeah. So this, sometimes the bend also straightens up, you know. So you see how it is looking now? You see it's almost straightened. You see that?
Was too long in the vessel.
It
Yeah,
was too long in the vessel, the bend has already straightened and that's why we were not getting it. So now if we make active bend, maybe it will go. Yeah, it should go there.
Yeah, I prefer also to use a SU03 in such very tortuous
Yeah,
anatomy.
there's a tortuous and you have
But the
two
SU,
branches. Yeah.
well,
There it goes. You see the bend had lost. That was the reason.
I need the other reference. Please,
Reference
keep
please?
it.
हाँ, उसको नहीं हटाना.
Okay.
Okay.
So now we are there. I'll advance the corsair a little bit to get more stability on the tip of the catheter, but it already
moving
goes.
forward. It's moving forward.
Already, there's one more tortuosity here.
There it goes.
Okay.
Yeah, that's excellent.
But now there is a bend.
There's
Again there is a bend. Yes.
one
and
more bend.
Posterior. And then it has to move forward.
Let's not ruin it here.
Yeah.
There seems to be another sharp
Yeah, sure.
bend.
Yeah.
Okay. So you let the heart work with the wire. That's the idea here.
Yeah, maybe there's few angulations still there.
Okay. Yeah.
Should we see in another view?
Maybe I should do an injection here to understand. Pull it back a little bit. Let's help take it out.
I see.
So this is the
Keep the-
contrast.
Yeah, 2 cc.
Dr. Nagamatsu,
So we
Are
want to
you-
have blood coming back.
are you rotating when there is a tortuosities or just you are pushing the cursor?
Yes. Yes, I want to rotate.
I think giving a tip injection to identify.
There was no contrast.
Yeah, maybe it's wedged there to one of
So
the.
I need contrast.
Contrast, please. Okay.
I think maybe we need to aspirate and recheck whether it's wedged or.
It's a little bit more difficult with the Xeon, but we didn't have the Suo for a long time, so
Yeah.
it should still work.
Sometimes they say that it takes as long as 5 minutes to have a backflow.
You
Okay.
see.
So you
Yeah,
have
you can
already
say good
probably
retrograde flow to the
crossed
septum.
the... No, you're still high. So there is a bend
Yeah.
there, which
Yeah,
in
there's
the
the
other
second
view,
bend,
There's
in the-
acute
which is
angulation
a little
there. You
bit
can-
tricky.
yeah, it is actually a zigzag bend.
Yeah.
You have to come down, go up, and then
So let's
the
see.
Z bend.
Let's see whether I modify my bend.
Maybe now you need a
Okay, Dr.
smaller
Bernard,
curve.
can you show us the
Yeah.
bend which you are
Probably we
giving?
need a smaller.
Smaller curve. So
Can you focus
we
on the wire and
have
show us the
another
tip?
wire, or you want
So what type of bends you are giving
Can
to
you-
cross
Yes,
this acute
yes.
double angulation?
Let's
Yeah,
get clean hands first.
Could you show me the
Show the
other
wire
angle?
tip.
Because this are separate connection, the junction
Yeah.
point, we cannot see clearly the
So
anatomy.
Dr. Matsuo,
Yes, please show me. You
so what type of shape you think should be there in this?
yeah, very, maybe the
It's almost
bending
90.
you need.
This is 90 degrees right now.
Yes, yes.
Yeah.
But before wiring, you should check the angiogram, another angle, because after crossing the very bending
We have
portion-
biplane.
We have biplane. Can you see the biplane? Can you show them the lateral simultaneously?
we cannot see.
The last angio was done in biplane.
You cannot see.
Biplane last angio dikhaiye. Can you show?
Okay, take it out. So I will go to areocaudal and take up your suggestion.
Yeah,
So this is a biplane shot that you are seeing. So you're seeing in both the angles.
Yes, yes. Yeah,
Actually,
we can see
in
that.
LAO, it is looking, it's getting overlapped over the LAD. That's the issue there.
So
The LED wire.
we do as you said. We will make another shot.
We can make it LAO cranial slightly, maybe.
Wait, keep it.
Okay. Okay. So there is,
You have a different view now.
it is slightly posterior. The main track is going posterior, and then you have to come anterior. It's posterior, and then you have to come anterior. So there is a good Z bend there.
Stop. Stop. It goes a little bit 180 degrees up, unfortunately.
Yeah, making a. It is a double U actually. I think it's going up and then coming down.
So let's see. The suo would be ideal, definitely.
Actually, I made a mistake.
I should have brought one.
No, I didn't click me that the SUO has come in the country, and those guys didn't tell me.
It's available now.
Yeah, it's available. It's just come.
Oh,
It's just come.
no, I need the reference that we just took, please. Go back.
Last angio.
Last angel.
इसको freeze कर.
Store.
Okay.
Freeze.
Go back.
Store. Okay. Yes.
All right. All right. Yeah. You're going. Your wire will actually go up. If it's correct.
Yeah.
Dr. Matsu, you have any other technique to do this now? What's your plan for this?
Like this situation.
Yeah.
You know, the
So
like,
you have two acute angulation
yeah, it's going
bends
up,
almost
that's
90
correct.
degrees.
and you know, like this very tortuous septal channel, and this septal channel vessel diameter is very big and very bending. Like this septal channel, sometimes very difficult to cross, and even though crossing the wire and advance the microcatheter, we cannot stretch the collateral channel. It's a big problem, maybe. So it's a very difficult, I think, this collateral channel.
Yeah, I think Dr. Goel will just
So
come back
the
to
C
keep
on
working.
black in
Dr. Goel,
Okay.
we'll come
We'll
back
try
in
to
2-3 minutes.
fluoroscore.
We'll go to the
Okay.
first lab.
Okay. All right.
Dr. Nagamatsu,
Right.
lab 1.
Yes. So I thought I would explain about the current situation.
Yeah,
Okay.
Dr. Nagamatsu, we are on live with you. Can you tell us how far you have progressed? I
Yes,
think you
yes,
have
yes.
already fixed the proximal lesion with a stent.
All right,
and
all right.
I think you have a anchoring balloon something there on the side branch. Can you tell us
Yes.
what you have done so far?
Yes, I would like to explain about up to the current situation. And so I already mentioned about I would like to fix the, before CTO PCA procedure, I would like to fix the proximal part. And so I insertion to the distal PL branch and using the Schönbrunn guide wire. Okay, anyway, so this guiding is 8 French and 3.5 EBU with side hole. And so this balloon is a 2.515. And I inflated this part. And after that, I checked another angle like this. And so I decided that stent size is 3.0, length is 15. And which kind of the Oshiro?
Oshiro stent.
Okay. And so I inflation and up to the 14 atmosphere like this. And after that, we can get good result. And after that, I checked IBUS. And may I switch to the IBUS image?
Yeah, please
Show the
us your
IBUS image. Show the
Yes.
IBUS image. Here, there. IBUS.
Can you see that?
Yeah.
Just a moment. So this,
Yeah.
okay, in this time we can see that. And so very big the echo enhance and include looks like a soft but actually hard. Sometimes is like the IBUS image. And okay, proximal part of the stent position and dilatation effect is so good. And there's no malapposition. Okay, please show me and go back to the CTO entry.
Yeah, we can see the vessel coming from the 12 o'clock to 3
Yes,
o'clock
around here.
position.
Yes, that's right. And so there is no significant flow in the CTO region. So I think there is no good and the fine channel in the CTO.
Okay, can you zoom the IBUS images and show the entry point?
Show the
of
IBUS there.
Okay.
Yeah, that's fine.
That's fine.
Yeah.
And come to the from the 0 to 3 o'clock, we can see the
Yeah.
circumflex. Okay. And there is no significant flow in the CTO region. And this sign is it looks like not so soft tissue. Okay. And please go back to the angio image. Yes.
Yeah.
Double lumen microcatheter. But and even if I did select and isolated this branch, but we cannot see that and good microchannel. Okay, and please discuss about which guide wire is better for as first guide wire.
Dr. Matsu, any comments? Dr. Matsu? He's asking which anti-grade guide wire would you select?
Hello, Dr. Nagamatsu. This
Yes.
is Coach Matsu.
Yes.
From the IBUS imaging, I can see clearly the tissue because this tissue is soft or not. I can detect clearly. So like this situation, using the VH IBUS is better for me. But you are now using Boston IBUS, so unlike this situation, maybe I use Gaia Next or something. I think.
I think the Gaia series, the intermediate was the Gaia second or next would be.
Maybe Gaia next to or Gaia second. Yes, I want to use. But this case is this sort of CTO exit is bifurcation. So the entry point, this sort of CTO exit entry the wire is very
Two
important.
branches, it's
Yes,
bifurcating. The exit point is
Yes,
at
I
the
will
bifurcation of the
say that
branches.
both branches.
So I think while you are working on that, we'll leave you for a few minutes. We'll go to the third case. Then Dr. Kapadhi,
okay.
Dr. Nagamotsu will come back to you soon.
Okay, sure, right, sure, right.
Yeah, keep
Hopefully
working on that.
faster than
We'll go to
yeah.
the third lab.
Okay.
Third lab. Okay, I think we'll go to Dr. P.K. Goel, lab 2.
Let's do ACT.
Yeah, Dr. P.K. Goel.
Yeah.
Here we go.
Yeah.
So,
Please tell us what you have done.
Go back to where we left. Yeah. The moment we
Did you see
left,
us on the second screen?
No, you were working on that angulation, so we have left you while we are working on that angulation span.
और उससे एक तुम सेलेक्ट कर लिया करो.
Okay. Go back.
ऐसे नहीं करो ना,
Back.
हाँ दिखता है ना ये.
Back.
Last
Stop.
round. Okay.
Show.
Start.
So
Forward.
next. So
That
you
was-
next. So as often happens when you leave someone in peace, suddenly it works.
So which were you
So this is
attempted?
the fluoro sequence.
Yeah. Did you change the
This
wire?
is the
It's the
fluoro
same wire.
sequence.
No, same wire.
Same wire.
Same wire.
Okay.
You saw the angle, 90 degree.
Yeah, we saw that.
So wait, this is a long sequence.
Yeah.
This is where we were still online.
969 images. Yeah. Maybe you have the next one where it crossed?
No.
This is the one it crossed.
This is
the
where it
longest
crossed.
one, yeah.
It's a sequence of 100 seconds.
Oh.
It's a big storage.
Yeah. You see, it had to make a Z bend, so
German
Go up.
technology.
it will move up and then come down. There it's moving up.
So I work actually, as mentioned, by turning. I turned clockwise here and waited for
Wire to...
for the heartbeat,
Yeah.
not forcing it, but just turning it and see whether the tip gets caught by the heartbeat.
Yeah.
It still takes some time, sorry, but
Yeah.
it should be shown that it is not a thing of 10 seconds.
Yeah.
Now we come closer, because I see the seconds here running on the store.
Yeah.
And now,
Yeah.
There it goes.
here we go. So then next we bring the wire into the PL, and you see the Corsair easily follows, even without turning, just pushing.
Yeah, after the
So this
120
is the situation. We need the B plane. It's still the Sion. Next
Yeah.
plane. Show the. No. The
Forward.
the technician needs
Yeah,
to
move
switch.
forward.
We can't see your angiogram.
Technician,
Yeah,
yes, here.
It's okay now.
Yeah,
Now you see. Okay, now we started moving the integrate wire, this XT, towards this target.
Yes.
Next, it's soft tissue, but it's resistant. Yeah. So now we come very close. It looks like we are almost there.
Yeah, you're at
Next.
the distal cap.
But this is misleading. Next. Now we did an angio. Next.
This is a biplane angio.
I already, here you see the antegrade wire on the A plane clearly going subintimal.
Yeah,
Yeah? While the retrograde wire, which is still the Sion, gives you the right direction. And if we would have gone antegrade only, now we had created
yeah, you create
Yeah,
a
that's the
subintimal
problem.
plane, yeah.
The
from
section at the
antegrade,
crux.
yeah.
Yeah.
yeah?
Yeah.
And this is just the next T. So now what we can do is try to get the retrograde wire along the antegrade, which is still an XT only, a Sion only, or use the retrograde wire as a marker and come with a Gaia type and have more control.
I think it's better to use a Gaia and have more control, because
What are your thoughts?
So I think you're going to change your retrograde wire from Sion to Gaia series, that's right?
No, I was thinking of changing the antegrade wire.
So what do you feel, Dr. Matsu?
I just removed
He is going to take a Gaia
and
wire from
the
antegrade.
retrograde,
Like this system.
and this is the
Very difficult,
retrograde
I
wire.
see.
You see, it goes.
So
No, this is Sion, this is not-
already enter from the retrograde with the wire. So like this system, maybe I want to advance from the retrograde with
Yeah.
the wire a little bit.
I think
And,
we feel that because you are already in the subintimal antegrade, subintimal plane
Yes,
in the
yes.
antegrade.
and before the bifurcation, they're performing the reverse cut, I think.
Dr. Goel,
What kind of wire would you prefer?
oh, we are thinking
Actually,
of
this
that.
buckling of the wire, I feel is not good.
Yeah.
I have a feeling this buckling of the wire tells us that we are subintimal and we are. Maybe
No,
we
no,
need
no,
to
no.
improve the strength of that wire.
Okay.
Yeah, we
Now
do
I'm
feel the
back.
same. I
Yeah,
think
yeah. The Sion
retrograde.
is too soft.
Sion is too soft. We need to improve the strength.
Ultimate.
Yeah,
So we
Dr.
can either
Goel.
have ultimate, bro.
I take an ultimate.
You want ultimate? Yeah.
So what we
Yes,
were,
please.
what the
So
panel
now
we were,
Let them.
yeah, what the panel we were thinking was we upgrade the retrograde wire to Gaia or something stiffer wire so that you can penetrate. Because the antegrade wire is in the subintimal plane.
Yes.
We don't want anything stiffer wires into that because you have
Yes.
two large branches coming from there. So maybe like a reverse car technique you could go ahead.
How much?
My preferred wire in this position for retrograde would be the ultimate.
Yeah,
Ultimate.
that's also
Ultimate,
fine.
Dedo?
With,
Oh. So we have the ultimate, bro, then, because it's finally
It's
Dr.
still-
Werner's choice. If he
It's,
wants.
because I don't do a directed cart yet. Yeah, if I have a
you don't do
directed cart with a balloon, then I would use Gaia from retrograde.
Yeah.
But if you are still working in the true wire crossing idea, then I would prefer the ultimate.
okay. I think Dr. Goel, while you are working on that, we'll go to the other lab and come back to you soon. So please switch on to the lab one. Dr.
You want to
Nagamotsu.
see how the ultimate crosses? Maybe the ultimate will cross. Maybe the ultimate will just go lumen to lumen retrograde.
Yeah, we'll come back
You
in
want-
2
If you want
minutes.
to see, then you can.
Give us 30 seconds.
Okay.
Okay.
ठीक
Okay,
है।
go to Lucknow lab, Lucknow. Okay, we are with you and
Yeah,
please
yeah,
show us how
just
do
see
you
this now.
cross.
Okay. Okay. Because ultimate is a hydrophilic wire and it with stiffness about 3 grams, I think. Is
Yeah,
that correct?
3 grams.
Yes. So this has some penetration power and it will, maybe if it may not go subintimal, and this is a good wire to try travel lumen to lumen. But I think maybe
The next option will be to bring a balloon antegrade there where the wire is.
and then do a
Yeah, that's
But
what
it
we
has
also
grabbed already the
Yes.
tissue.
Yes.
Yeah, it grabs the tissue. You feel
Yeah,
it. You see it.
Yeah, that buckling actually is not a good sign.
Yeah, I think
Buckling
you have
tells
done
you
that.
that the wire is going in the wrong direction.
No,
and-
it's strength.
And the moment it grabs the tissue,
Okay.
means it goes straight, and that's where it moves.
We check in the other plane because never be too sure.
I'm sure.
But it looks, yeah, it goes a little bit outside here, but we can bring the balloon now, antigrade balloon, create some space
How is it?
for the retrograde passage. Okay, so you can go to the other lab, I think.
Yeah,
Yeah,
we'll
please
do
work
the
on that.
reverse cart. We'll prepare for the balloon and stuff.
We'll go to lab 1, Dr. Nagamatsu.
2.
They are chanting even. Every time Naga.
Yeah,
Even
yeah,
Arvind also is saying their name.
Dr. Nagamatsu, you're with us? Can you hear us?
Yeah.
Okay.
Yeah, please
Actually,
tell
they
us
are
what you have done. I think you had a great progress. I think you have reached the distal fibrous, distal cap. Can you tell us what you have done so far?
Okay, just a moment. I'll explain. Okay, and so I already showed the IVA study, and so
Yeah.
and after that I tried to negotiate this procedure by the antigrade. So I would explain about this system. So I insertion the Sionburu guide wire for the small and insertion to the small PL branch, and after that I insertion the Boston IVAS. And then so that I use a double lumen microcatheter and insertion on the same guide wire. So that means this Sionburu guide wire and have the two systems. One is IVAS and another one is double lumen microcatheter. So firstly, we know and there is no significant microchannel, but I tried to using the XTR guide wire. So that's why from the CTA angio, and there is no severe tight calcification, but failed. And I step the guide wire from the XTR to the Gaia first, but very easy to occur the prolapse to the distal and the PL branch. And finally, I step up to the Gaia second. And so to be lucky, this Gaia second guide wire and get advanced to the through the CTO entry like this. Can you see this flow record? And after that, I immediately check in the IVAS. Or please switch to the IVAS.
IVAS.
Is this the last one?
Yeah.
Okay. And so I started this IVAS study from the PL, and we
Yeah,
can see the
you can see the wire.
second guide wire, and from the 1 o'clock. And please show me again.
Yeah, you can see that around 1 o'clock you have a guide wire.
Yes, so the vector,
Yeah.
this direction is the same as the center of the disc circumflex, I think. Do you agree with? Yes. But unfortunately, the distal part is unknown. But from this IVA study, it seems like maybe the correct way and get advanced to by this Gaia's second guide wire. So I believe this Gaia's second wire pass through the CTO exit via intima. Okay, please switch to the angio.
Angio.
Okay, thank you.
I will remote with you.
Yes, and after that, I immediately check the angio from antegrade. And so this image is the same as the IVAS marking and before insertion of the CTO region. And after that, I check the contralateral injection is not so bad from this other corner view. And continuously, I get advanced this Gaia second wire. So my hand feeling is not so bad. And a little bit I feel the resistance and get advanced guide wire. And from this fluoroscopy, we can see the deflection and the moving. A little bit this guide wire get advanced to the left side. Can you see that? A little bit moving. Yes. And after that, I checked again. and from the contralateral. Yeah, looks like okay. Looks like okay. And a little bit I get advanced, only the, I don't know where, only the 1.0 millimeter on, and get advanced like this, and I check again from the contralateral injection. Still this direction is not so bad. And in this time we have to check the another angle. I check the area corner view. From this area corner view is almost okay. And looks like this guide wire, second guide wire tip on the top of this bifurcation. But this session chairperson, Dr. Matsuo, said, and for this case, the most important thing that even if the pass through this guide wire through this CTO region, but we have to insertion the best position of this bifurcation. So my plan is, okay, and so we can see the quarter channel, mainly quarter channel from the PL branch, distal PL branch. So my plan is, if we can, I would like to try to the insertion to the circumflex distal part. And from this area corner view, we have to change, tip change. We have to the direction of the tip, we have to change to the more downward. So this is up to the current situation. Okay, and then go back to the area corner, please.
Hello, Carol.
Yes, area corner.
So you are going to further go anti-grade wiring, or you want to change it to the retrograde to wire as a marker or something like that? So
Yes, okay, and from the APCT algorithm, and if we have to keep this distal bifurcation of the DCT exit, and the best way is consider about the retrograde piece of procedure. But as you can see, and this retrograde channel is not so promising. And actually, 6 months ago, so we cannot see this channel. And even if after the 6 months later, so now it's growing up. So very quite tight, and a very severe beating motion include this apical channel. So I'm afraid of even if the pseudo-0 guide wire, maybe and happen occur to the perforation. So my plan is firstly I try to the anti-grade. Do you agree with?
Yeah, we agree if we can go easily to the anti-grade, that's fair enough. But we are only worried that we don't want any subintimal plane or something because we have 2 large branches coming up.
Yes, we don't know
bifurcation
that.
lesion.
Yes, please save fluoro. Yes, and please repeat this save fluoro image. Please run, please. And before I mention about, I would like to get advanced to the downward. Okay,
Any
run,
comments from the other panel? No.
Run, please. No, in this image, this flow image, please run this.
Dr. Nagamatsu?
I can.
So
Yes?
you mean you want to advance the Gaia second to the distal circumflex, not the PL?
Yes,
You mean-
circumflex.
Not the direction of the wire to the distal circumflex, not to the
Yes.
PL direction.
Yes, and so
Okay,
I will show you. I changed the direction.
Okay, I
And
see,
from the PL to the circumflex.
I see.
And yes, and so that this guy second wire so very is quite good and handling
Yeah,
given like
I think
situation.
so. Yeah.
Hopefully, I would like.
Yeah, I agree with you.
Thank you very much.
In the crossing to the PL, the Gaia second, if the Gaia second shortcut to the PL branch, then
Yes.
maybe it's very difficult to get the distal circumflex, I think.
Yes,
So
I will.
I agree with you.
Yes, and so from this spider view, and maybe the correct direction. Okay, and I would like to check another angle and other quarter view, please. Yes.
Carol, come.
Yes, 30. Yeah, but I know it looks like easy, but in this time very easy to get advanced to the subintimal space, so I have many experiences. Okay. A little bit moving. Okay, good. Looks like not so bad. Not so bad. Okay. So this direction is maybe okay. I try to get out of bounds. this guide wire. But in this time, usually we have to step up guide wire. But this region is quite short, very difficult to the conventional microcatheter.
I think,
Yeah, I don't know.
yeah, I think in fragmental.
Okay.
That's it.
Please say floor.
Yeah, maybe.
But
It's looking like subintimal.
I think we need to see in some other view.
Yeah, some other.
yes. Okay, please change to the yes.
Yellow color, complete.
So my plan is I would like to get advanced circumference SR part, but in this time it's not so.
But from this imaging, your wire direction is okay, I think. The position is maybe not so bad.
I don't know. My feeling is not so good. But looks like get in the. Okay, looks like get in.
This is looking okay, but there.
Yes. Okay, go back to the other corner.
Arrow cutter, come.
From the both direction, this wire position be in the true lumen. Do you agree with?
Yes, I think so.
Really? Thank you very much. Thank you very much for the encourage. Okay, please just a little bit moving.
Yeah, I think that Nagamatsu, while you're working on that, we'll leave you for a few minutes. We'll go to the other lab and come back to you.
Okay.
Yeah.
See you later. Thank you.
Yeah, Dr. Goel.
Go back. Go back.
Yeah.
Back.
Yeah, we are with you. Can you
So
tell
now
us
you
how-
can come with us live.
Yeah, we are with you.
Okay. Go back, please.
Back. Okay.
Start.
So we brought a 2O balloon over the Fielder XT and inflated, and then I tried to get with the ultimate into the same space. I struggled a little bit, but finally we managed. We were thinking you could easily
Do it with a Gaia.
change to a Gaia, but so here first what you have to do is get the Corsair further up, maybe even in the distal cap. So that's still the process. We keep you a little bit under suspense. So here is the Corsair coming now.
Yeah, you could advance the catheter or micro catheter into the distal RCA.
Yeah. So, and now we have more control. Next. So this is now where I try to get a little bit more in the sequence of the balloon. The balloon is inflated, deflated, space is created, and now we are through. Next.
Yeah.
Now we go up. We inflate with a balloon. It's not a card procedure. It's just making space and give the wire a rail with the balloon. It's a 2O balloon. It's a huge vessel, so it's not about creating dissection. Next. It's just a rail for the wire to get under the balloon and up into the guide. So this is when we want to enter, of course, the short amplets. And as we use side holes, it gets out of the side holes here.
Yeah.
Yeah. Okay. But finally we made it, and this is where we are.
So
Now the Corsair is up there, and we release the trap. The trapping balloon is released. I remove my Yeah, the Corsair is
Corsair
just
should be
at the
little
border.
more. Yeah, it could be a little more in.
Okay, what we can do is just
Okay.
give it 2 atmospheres. It's 2. I trap it. It's a little bit awkward.
Yeah.
Yeah. I should have kept it a little bit upwards,
Yes,
but it's
Corsair
just,
should be a little more higher actually.
Yeah.
but it doesn't matter.
Yeah.
So RG3,
Yeah.
we don't need to bend it.
Or maybe it's in the
Well,
tip of
if
the-
I slip out, then it was, I go back in, it doesn't matter. So then basically we will try to dilate. I think we will be true lumen all the way.
Yeah.
Yeah, I think this should be. Maybe there will be dissections certainly because we have gone subintimal.
Yeah, but we
a few
didn't dilate.
times.
So
Yeah, we
you
didn't
see the
dilate.
balloon, the wire is in, so
Yeah.
down with the balloon. So. And now we just have to wait until it comes out from the
We
other
need to
side.
open up there.
Yeah, but only when we are close. After having done a number of retrogrades, you know when the RG3 is coming. We have long catheters. I would prefer, of course, for retrograde to do it with short catheters. Well done.
Oops. No, is it done?
That was a fellow who did that, huh? The fellows
Let me see.
put the thing. Wait, it's coming soon. Where is it?
There it is. There it has come.
You see it? It's already
Yeah.
out there. So,
So you need to move this forward and get it in. Actually, the strapping is fighting with
down.
Yeah, Dr.
So now
Boyle,
we
the
have
wire
a lot
is
of
in,
blood
RG3
here
wire is in.
on our hands.
Yeah, wait, it is out.
It's
RG3
out
wire
on
is
the
out.
other side, and now
Can you see it or you can't see it then?
2 elderly physicians trying to find the wire.
You see, just a sec. Where the hell is it? No, it's probably. Where the hell is it? No.
Let's get the balloon
You
out.
get this out. You just see everything is okay when you're getting it out. You will need to pull this out for a moment. Okay.
No, we have
No.
now everything out.
Just a sec. The RG3
Sure.
Yeah, there is the RG3. Okay.
Okay.
Now you need
Get
to
all the wires out.
get this all out.
So there's the RG3,
Yeah.
It's going to
and
come away.
it's bleeding, okay. But this is straightforward. So if you have some more interesting things going on in another lab, we would dilate and then do probably IVUS, or should we do IVUS?
Yeah, we can do IRS.
Yeah.
Because it's important to decide the strategy.
Yeah, I can't see from this.
The strategy
Light over light, give me light.
at the
Yeah,
bifurcation, whether
Yeah,
we get
you-
away with 1 stent or 2 stent.
I think you dilate that and you check on IVUS, and while you're doing that, we'll go to the other lab and come back.
Just a sec.
Dr. Goyal?
Push this. Push.
Yes,
This
okay.
is the RG3?
Yeah. I think that Dr. Nakamoto, we are with you. I think you have made a significant progress. Can you tell us what you have done?
Okay. Okay, I explain. So actually, it's not so easy for me. Okay, and very close to this guy's second wire, and like this, and so I insertion to the looks like PL branch, yes, and from this other corner view is okay, and from this spider view is okay, and so I get advanced this guide wire, so there is no severe hardness, and very smoothly get advanced this guide wire like this. So I will show the same flow like this. It looks like I get advanced to the lumen, but this guide wire position is different. So I don't know where. So this one is a small branch or the perforation. I don't know where. So that's why. So this is a dia second wire.
Way away from the true lumen.
Yeah, but anyway, so in this time, so if this Gaia second wire take out and the insertion is like a gamble procedure, and this is a situation very easy to get advanced to this guide wire, get advanced to subintimal space, and so my plan is keeping this guide wire. And additionally, so I would like another guide wire and using a double lumen microcatheter. This is my plan. And so I remove and this IBUS system and the double lumen microcatheter. So this microcatheter on this Sion blue and the PL branch. And this additionally, I use the double lumen microcatheter on this first guide wire. And first guide wire means the Gaia second wire. So this is the current situation. I try to the parallel wire technique. Okay. The connection, this one? Okay. And what procedure is best for in this situation? So it looks like this guide wire passes through the distal to the lumen, but this guide wire passes through the small branch. I don't know where. So my choice is a parallel wire using a double lumen microcatheter. Where it's and it's additional guide wire is a Gaia third.
Which double lumen guide catheter you prefer? Microcatheter you prefer?
Yeah, and so in Asahi and Asahi double lumen microcatheter Sasuke. Thank you very much.
Where exactly you want to put the double lumen microcatheter? You wanted to come through the CTO body also to the distal body, you wanted to keep it, or at the time of proximal cap itself?
Yes, and but so I think that if the insertion the double lumen microcatheter, even this one, but I worry about automatically take out this first guide wire. Another option is inflation and CTO body, and on the this first guide wire route, but I don't know where. So this route is this part is perforated or not. So my choice is a purchase and the first guide wire. So I think that this first guide wire is a Gaia second, and the additional one is now is a Gaia third. So, and a little bit more easier than previous. Can you see the tip of the Gaia third? I think the same same angle. Okay, same flow. How about this? Just touch with the cap.
Do you have any comment from panelists? No?
I'm waiting.
Dr.
So
Nagamatsu is now
yes.
using Gaia third for the second wire.
Yes, as a second guide wire. The same one is better or the more hard one is better. And Dr. Matsuo previously said Gaia next is better and for the as the first guide wire.
Is trying to go into the digital LCS or the real time?
No, my choice better depend on the situation because Gaia Next is not available in India yet. So maybe if I'm operator, I try to standard Gaia.
Okay, thank you very much. But still difficult to get advanced. And even if I use Gaia third, but very easy to occur pull-ups.
This situation from panelists, which wire do you want to use? Already, then Dr. Nagamatsu is using Gaia Start. What kind of wire do you want to use?
How about Conquest?
I think it's one option. How do you
Option.
think? Like this situation, maybe the Gaia Start cannot control and cannot
Please say Floro.
advance, so maybe
I take it.
switch to Conquest Pro is better, I think.
Okay, and I will check another angle. And please move to the spider
Just
view.
to penetrate the digital cap.
Yes, yes. And already this wire, the Gaia second into the CTO body, but even though using Sasuke with Gaia third cannot perform, so like this situation, maybe switch to Conquest 3 is better, I think.
Conquest. And from the beginning?
No, this situation.
Okay.
Because you can, the guy already you using the Gaia third,
Yes.
but cannot control and looks it's a little bit difficult to advance.
Yes. The entry point is very difficult to pass through.
And like this situation, we usually are afraid of create hematoma to the distal bifurcation. So
Please save Floro.
okay,
And I check
Dr.
the
Nagamatsu,
answer. Yes.
we want to move to the another.
Okay, please save Floro.
There is only 3 minutes of
Francis,
transmission
back.
time. So we'll go to the other lab and come back.
The LAO, I want to
Yeah,
see the vessel
The
a
IVAS
little
is
bit back.
Let us show them the IVAS.
Okay, here. So that is, keep this for orientation. They are coming back to us?
They might, yeah, they'll
Yeah,
come
Dr.
first.
Goyal, we are with you now.
Hello?
Hello.
Yes. Yeah. So now, you see, we have already externalized the RG3 as we showed you, and some balloon dilatations were done. So Dr. Werner did about, initially did 2 millimeters, and thinking that we might be able to cross the IVAS and see the IVAS pictures.
But you see that...
But you see this dent here, very severe dent.
Yeah.
So we needed a bigger balloon, and it gave up at about 18 to 20 atmospheres.
Show me the...
Picture, image.
So first you tried to pass the IVAS or you are not tried at all? Directly you are doing the balloon dilatation to facilitate to
No.
pass IVAS.
We are now with the IVAS. We are now with the IVAS.
So now IVAS is coming.
Because we need to see where all the dissections are there, what are the size of the distal vessels.
Dr. Goel is more pessimistic than I am. I don't think we will see much of dissection.
Acha.
Okay,
Let's see.
so
Okay, so that's where we are.
maybe it's... yeah, well, this is the problem with the Boston system. I need to get back with the Corsair a little bit, probably, to get more space to advance it further.
So that is in the PDA?
That's definitely in the PDA. Let's
Okay.
make a pullback.
You make a pullback. So now you see the PDA is about 1, 2, 3. It's at least 3, huh?
Huge.
Huge PDA. 1, 2, 3, 3.5 rather, I don't know. It's at least 3. It's at least 3, yeah. So we are doing a pullback.
Are we doing?
Yeah, it's moving. It's moving.
moving?
It moves slowly.
Yeah.
So that's
Now
the
it's
side
the
branch.
PL.
So you want to?
Maybe it's the, no, PL comes here.
Okay.
I
Can we
think-
see fluoro where it is?
Let's see.
Yeah.
Maybe it's
That's the PL coming in.
so
That's the
many
PL
side
coming in. That's the PL coming in.
completely healthy.
And it is all within the lumen. There is no.
So we really see it's soft fibrous in the plaque, intra-plaque.
Yeah, intraplaque we have. I think we crossed intraplaque, the whole lesion, most likely.
Yeah, definitely. So this gives us a clear
Small-
picture
small speck
that
of
we
calcium.
can stay
No, but
with one stent
this
strategy.
is subintimal. This is subintimal. We
No,
just,
it's not.
There was a small
It's not.
segment. No?
It's not.
I think we
There's
had,
still material on the
no.
bottom.
Transiently there was subintimal and then we entered again.
We'll review. Let's
Yes.
see where we are. Of course. So we are still, yeah, it's the site where we did the ballooning.
Yes.
So of course, there will be a dissection from the ballooning. But it's not classical subintimal. It's just the tear of the balloon.
Yeah, I thought a localized site there was, we were subintimal, the artery was on one side and then we entered again.
So definitely the crux is healthy.
What about this place?
It's still material. It's all plaque. We are still in the site of the occlusion. Where the plaque is. Now we are proximal to it.
Now we are proximal.
This is very slow speed, huh?
Yeah, the speed is slow. I think we've crossed the main part. This is where the RV branch would come. Can we see fluoro? That's the RV branch. That's the RV branch there. And that's where our balloon was not giving way. There's, I think, severe lesion there. And
So the panel, would the panel agree that we probably put the stent towards the PDA and leave the PL and do a pot? Or would the panel prefer to go to the PL for the stenting?
I think PDA is, you're already seen that it is more than...
Are you with us?
In the IVAS wise, the PDA is already demonstrated
Yeah.
at the more than 3 millimeters. I think it's better to stand towards to the PDA.
I think there is no
Okay.
decision in the PLV. I think we can leave
Yeah, I
the
think
PLV.
that's...
yeah, that is also one logic. And the other thing is the PL seems to be open. There doesn't seem to be a dissection at the point where PL is joining.
Yeah.
So maybe we would be okay. All right?
Okay.
we
So
can
that
get
looks
the
very
IVUS
good.
out. So we get the IVUS out and we try to do the stenting part.
And we'll, yeah, do we need to prepare a little bit more? Probably not.
I think
So-
we've done 2.5s.
Yeah.
I think that's fine. We can do a 3.0 stent distally, is it?
I'll just check that I get the corsair a little bit more distal, that we protect our collaterals. And then we prepare the stent.
Yeah. So
What
can
do
you
we-
get me a 3.0 38? Let's do a 3.0 38. Maybe we'll need 2 stents.
At least 2 stents.
Yeah, at least 2 stents. Whichever. You can give me a promus.
Okay,
Or-
your plan is stenting from the
Ek promo de
PD,
do.
Keep it.
PDA, the crossover.
De do.
Yes?
Okay.
Yes. Crossover. You agree?
Yeah, which...
Yes, I agree. So, can I move to Dr. Nagamatsu's room?
we just review it once. Just review it. शुरू से दिखाओ इसको.
Okay, wait.
हाँ, just run it. So,
So
we have,
let's do an angio.
you
for
want to do an
orientation.
angio?
To see
Contralateral?
where the... No,
native?
antegrade. We have no dissection.
Okay. So let's do an angio.
to place the stents.
Yeah, biplane angio, RAO, LAO. Okay. Come on. Yeah,
Ah, huge.
that's where some little dissection is there. Is there some?
This is where the ballooning was
Ah,
done.
yeah, but that's what is.
I don't think that we are really subintimal.
No,
Make
no,
it store.
okay.
Reference. So 30.
338, I think. 338, Ekdo.
Dr. Goyal, can we put the stent
Yeah.
just before the bifurcation?
Yeah.
Can we able to put the stent before the
Yeah, we'll, I think, Dr. Werner, what do you want? You want to put it before the bifurcation?
No, I don't, because it was a flush occlusion. I don't think, the only
I
thing
think
is
we'll
we
cover it.
could miss
Yes.
the
So
bifurcation.
I would also think we should do it across the bifurcation so that we don't miss anything, and the side branch is already open. We have an open PLV. So I don't think there is any worry about losing the PLV.
Dr. Goyal, I think it's
So we have two
excellently,
long stents. Yeah.
excellently you demonstrated the retrograde true lumen, you are entered into that, and you had to stent it. And the previous
Yes,
case
yes.
from the Hyderguda, they wanted to show it.
Yeah.
Can we shift over to that? Hyderguda
Yeah.
Apollo? Okay.
Okay, we'll show you the final picture if you will
Yeah,
just come
Anyway, we will continue
for a
with them.
moment
That
before
is-
we end. We'll show you the final picture.
Yeah, Dr.
Yeah,
Goyal, we are
okay.
going to continue
I think
with
that's
you.
fine, isn't it?
Yeah. We are going to continue with you. That Hyderguda case is not yet finished, I believe.
Okay, okay.
So
Dr.
what
Werner.
we will do now is, what is this?
This is just to fill it negative. That's what I usually do. So,
Okay, so get the balloon on the stent,
balloon on the?
the indiflator on the stent.
हाँ, लगाओ उसको.
So I will try to do the contralateral injection as a guide for the stenting. But it could be that the flow is already too good.
Yeah, because we have already filled it antigrade so well, so you
Yeah.
wouldn't see.
But let's see.
You won't see much from
Let's
the
see.
contralateral injection. You're not seeing much. You're not seeing much.
No, we are not. But a little bit.
You're a little bit forward. You need
Should
to move.
go forward a little bit.
Your corsair needs to come back maybe slightly.
So I'll do an antigrade test.
Maybe you need a cranial. Is it okay? That's better.
It's too far, a little bit too far.
I think it's okay. You'll miss it.
Yeah, well, the crux itself was healthy. If we manage to stay... So, okay.
Okay, fine.
That was the wrong side. We waste a lot of contrast at the end of the procedure. Well,
think
we
that's
can
fine.
go up and then do a pot.
Chalo.
Yeah. Chalo.
Fluoro, please, or whatever, 10, 12. That's the crux part.
Okay.
12. Okay, so we are up to 12 atmospheres. I don't know. Are we live?
Store.
Down.
Down. So we go anyway with a 3.5 or maybe
Yeah.
even a 4.0.
3.5 approximately,
But
maybe.
go up full 18, 20, whatever, and see what kind of length of stent we need proximal.
We probably need
Down.
another 38. Kitna, what is the length? Do you have an idea? From up... no, because
So,
we'll need
here.
to do an IVUS here to...
I'll pull out the catheter and
This
then we
part
can see.
is subintimal, isn't it? Here you don't have the three-layer structure. This part...
No, it's still structure. It's black on the side.
Yeah, the black on the side. So our wire is subintima and then it will go back into intima. This is what I had seen that time.
Should be just good, huh?
38 should be okay, I think.
Yeah.
One more 38, please.
But 3.5 or 4.0?
3.5.
3.5.
Well, just a sec. Show me the proximal vessel size.
We are
Proximal.
just reviewing the IVUS here.
Just a sec. 1, 2, 3, 4. Well, it's about 4.
Shall we go with a 4? Yeah.
You want to go 4? Let's
4.
4. I don't know. 4. The 38 you have.
No, let's get 3.5, and we can use the 3.5 for the distal, and then do a
Make
4.0
a 4
non-compliant.
That will be better. 3.538. Zines.
The question is, and will you bring the patient back for the circ, the distal circ?
No, I don't think I will. Now, this is a question which Dr. Werner has raised to me, but I am reasonably sure I will not get the patient back for circ, because circ, you see, the main branch has already come out, the big OM. The distal OM by myocardial value, I think it is not more than 10% of the myocardium. So I give a score of 1 or 1.5 maximum out of a score of 15 on the total myocardial value in our system that we follow. We follow the Green Lane system.
Okay.
So it's about 10%. So for a 10% vessel, doing a CTO is not worth it. So I don't think I'll. Okay. So you get the logic that I talked about the myocardial value of a vessel and which one to do and which one not to do.
Yeah, that is
And
true.
there's too
That
much
is
overlap.
important. The percentage of the vessel supplying the degree of the myocardium is the determinant. If it is very small,
okay, go ahead.
it's not worth
Go ahead.
taking all the
Yeah,
pressures of
quick.
CTO.
Go.
Up to 12. Yeah.
We are not able to see the angiogram pictures.
Why? Little more. No, more.
We are having IVS pictures. We don't have the angiogram pictures.
Because the dent has to go.
Get on the angio, the technique, yes. So,
Down.
so now we try to get to the crux with a stent balloon. Is it deflated?
Yeah, deflated it. To move this forward might be difficult. Yeah.
No. Let's
Hello. Are you able to hear?
Yeah.
Hello.
Just we left at this stage. Next, we made multiple attempts with the guideliner, with the Corsair support, and we used many retrograde wires, including Gaia 1, 2, 3, Gaia next. But we cannot puncture that proximal cap. Very difficult. So finally, we used, with the Corsair support, we used the 820 Conquest also. Next. You can see, this actually, the Conquest 820 appears it crossed. Next. And now you see, now it appeared as it crossed and I am happy that time because a very, very tough case. But unfortunately, in the next shot I have seen at the bifurcation, it appears very promising in all these views. At the bifurcation point, it is a subinterval. Next shot. Next, you see that. Almost we thought we completed, but next. So here it is in the subinterval. We have actually tried next a reverse cut also. We tried ultimate boss, then miracle 3 wire. Next. We have done the reverse cut with a 2 millimeter, 2.5. We have done an IVAS. And the IVAS pictures will be showing. So with the 2.5 millimeter balloon, also we have done the reverse cut at the site of CTO segment. But it's difficult to negotiate the even numerical 3 wire up. And to capture that, I use the guideliner again. Next. We made all of it. That's the guideliner. That's the last thing. We could not get into the guideliner also. If you see the IVAS pictures, can somebody see the IVAS pictures? we recorded the IVAS. Actually, part of the anti-grade wire in the 2 lumen to some extent, but distally it is in the subintimal plane, and there's a lot of hematoma collection, subintimal collection. That's why we thought it's already 7 gray. We touched it. So I felt patient and ourselves getting exhausted. So we abandoned at this level. Before coming out, we checked the left injection next, and all collaterals are well preserved. The distal vessels, branches are well preserved. So there is no coronary injury, there is no pericardial effusion, except some vasovagal he had, but he recovered. Otherwise, he is okay.
Yeah.
So maybe we can have to take further assessment of the lesion by CT angio, and whether we have to adopt some other aggressive procedures for this.
Yeah, even I agree. Where we have to stop, we should know it. And this is the best time actually. You tried in all the ways, and there is a hematoma. So you can aspirate the hematoma, or you can wait for the some more time.
No, he is stable only. He is stable only.
Yeah.
So we did not do anything. But at one stage, if you see the angio, the Concus 820, we used that crossed the lesion, entered the distal collateral channel. Unfortunately, I thought there is a false flap in the bifurcation area. That's why I did not go further.
Good. It is a good demonstration of the many things actually. In a single case, you demonstrated the reverse cut and the difficulties with the stiffer wires using. Even everyone, all of us are recommended to use that, but still you used and it is not possible. I think it's a good educational study, educational case. Thank you very much for showing that.
Thank you.
Thank you very much.
Thank you.
And can we go to Dr. Goyal just to tell him a thanks that he did a good demonstration and all that?
We are.
Please show the final angio.
So have you seen the final picture?
Just
show the
static image.
So we are just proximal most probably needs one more small stent. We have already. You can see that you can see this last biplane.
Then the other plane, we want to see the other plane.
Biplane, the last shot with biplane.
No, they should. The technician. Let it run.
Let it run.
Let it
इसको
run.
चलाओ. इस एंजियो को चलाओ. हाँ, चलाइए इस एंजियो को.
Anyway,
नहीं, आप माइनस करेंगे तो आपका एंजियो चलेगा ना?
So let it run.
आप माइनस करेंगे तो आपका एंजियो चलेगा ना? हाँ, चल रहा है आपका एंजियो.
So now you see it. Looks quite good.
There is some proximal
But
lesion.
proximal, there is a little gap where we will.
Yeah, so we are just going to add one more stent there.
Yeah,
Come on,
but excellent demonstration of retrograde wire coming in the true lumen.
Nice.
Thank you very much, Dr. Goyal and Dr. Werner.
Thank you.
Thank you very much.
Our pleasure.
Yeah, actually morning Dr. Hamazaki has done a case in the Nizams that is also in the final stages. We are not able to show it, and he's done excellently the retrograde wire crossed, and he done the exteriorization and the stenting. It can be shown after some time. Now we are running short of time, we will show the CD subsequently. Now I will request the next session to start it and the speakers to come on to for the presentation. Thank you. Thank you all, sir.
Dr. Nagamatsu wants to come. Sunshine.
You can.
Maybe. Yes. Okay, so I explained up to the current situation. So finally passed through the guide wire using Gaia-SAR. We're lucky with. And so I already explained about up to the parallel wire technique. So the first wire get advanced to the small branch, I don't know where, but anyway, so this Gaia second wire is passed through the not distal big true lumen. And so I decided to additionally the insertion of the guide wire using the Gaia third wire. So mean the guide wire step up and using a double lumen microcatheter like this. And so finally so I induced this Gaia third wire and same as the first guide wire, Gaia second like this. I checked several directions like this. And so, and from the spider view, yes, very close to the top of the bifurcation. And from the aerial corridor view, it's the same, it's the same, it's the same. And so in this time, so that anyway, which it looks like a bit difficult to the insertion to the circumflex, and which is the easy way to get advanced is a PL branch. So I decided to the insertion the PL branch. And so I will show the fluoro image, and this is a yes, and in this time pass through the to the PL, disturb the PL branch, big one. This is the guy third, and so I check, and the angio and the angle is okay, and so my feeling is quite good, and definitely this guy third wire pass through this true lumen, very lucky. And then after that, I extend to the guide wire from the guide third to the Xion blue, and using the Corsair 135. So that's why I use the Corsair. And as you know, the Corsair have the dilatation effect, like a 1.0 millimeter balloon dilatation. So I afraid of the created the big dissection at the bifurcation. So that's why it's just after that, if the created the big dissection, very, very difficult to the insertion to the circumflex and another guide wire. And after that, and pass through this Corsair, and I take this Corsair and Corsair dilatation, and amazingly this and double lumen microcatheter is pass through this CTO region, and without balloon dilatation like this. Can you see that? And then so that I try to the insertion the guide wire and using the Xion guide wire. And it looks like this Xion guide wire pass through the CX. Okay, this is the current situation. And so I try to the dilatation using a 2.5 balloon.
Yeah, actually you could succeed very well by using the Crusade and using the Gaia 3 to the true lumen. And
Yes.
it's really the excellent demonstration of
Thank you very
the
much.
shorter segment CTO with the
Yes.
proximal disease. Yeah,
yes.
we are
Looks
very
like
thankful
easier.
to you for your live case and excellent educative value. Thank you very much.
Appreciate. Thank you
Yeah.
very much.
Thank you very much, sir.
Thank you very much. Appreciate.
Yeah, thank you all of you from Sunshine for giving us the opportunity. It's an excellent opportunity to show a IVAS guided puncture and double lumen catheter usefulness and a wide escalation strategy, starting with the XTR and Gaia 1, second, third, and nicely demonstrated again double lumen catheter entering into the another branch. And really it's a very nice, excellent demonstration. Thank you, sir. Thank you for
Thank you
coming
very
and
much.
gracing our
Thank you very
occasion.
much for your
I
help.
wish you all a great day. Thank you, all of you from Sunshine. Thank you.
Thank you,
very
Dr.
much.
Kasturi.
Thank you.
Yeah, we will go to the next session now.
May
Thank
I
you.
thank all the chairpersons and experts
Thank
who
you very
joined
much.
us in this last session. With this, we move on to the very last session of this conference. May I request the chairpersons of the next session to please come to the dais as I call out their names. Dr. V. Suryaprakash Rao, Dr. Arun Kalyan Sundaram, Dr. Tripti Dev, Dr. Sarvanam, Dr. Jagdeep Yadav, Dr. S.K. Sahu, Dr. Srikant Shetty, and Dr. M. Sitaram. In this session, we would have 5 speakers. May I request you to all come to the stage. Thank you.
May I invite Dr. Nagesh Wagmare for his first presentation. He has an early flight, so there is a little bit of shuffle. Dr. Arun Kalyan Sundaram, Respected Dr. Kenya Nasu, please take over the dais. Dr. Nasu, your talk will be after Dr. Wagmare. After his talk,
Oh, God, no. So, Dr. Nasir,
you can be seated at the dais. After the talk, you can.
just take through your talk and then leave. I gotta leave too, so. So what time's your flight at? 4? Yeah, mine's 5:15. If it's 4, you better leave like now. Okay. So this is probably the best thing. Put your mobile thing and then I'll just add you. You don't use WhatsApp, is it?
Good afternoon, respected seniors, colleagues, and the August gathered here. Thank you, organizers of this conference. Thank you, Dr. Shah, for giving me opportunity to speak early because I have a flight to catch. I'll be speaking on antegrade dissection re-entry, subintimal hematoma management. I'm Dr. Nagesh. I'm Associate Professor in Grant Medical College, Mumbai. So during this presentation, I will go. I'll go through what is exactly ADR subintimal hematoma is, why should it be treated, and how to manage if it occurs. So quickly, I will go through it. This is the pathophysiology, the graphical representation. We can see when we try to create antegrade dissection electively to bypass the body of the CTO and create a dissection to re-enter into the true lumen distal to the CTO body, there is a possibility of seepage of blood from the false lumen into the vessel wall in the media, because there is a significant pressure difference in the blood flow. Proximally it is systemic pressure and distally it is significantly reduced because of the impact of the CTO, and there is a blood accumulation inside the media separating the internal and external elastic membranes and occluding the true lumen of the vessel distally. This is by definition accumulation of blood within the medial space displacing the internal and external elastic membranes with or without identifiable entry and exit points. So these two images, one is pathology slide and another is IVUS image, which showing a crescent shape hyperechoic shadow in the IVUS especially, which is compressing the lumen. This is the internal elastic lamina, this is external, which is displaced, and there is an accumulation. So this is a classical IVUS picture that typically we see when there is a subintimal hematoma formation. These two images are from two different patients, but they are correlating. That's why they are given together. This is how the IVUS subintimal hematoma correlates with the angiography picture, where in this patient there is a post-stenting. There is a stent here in the lesion, but after stent there is compromise of the lumen of the vessel, and the reason on IVUS found to be subintimal hematoma. So for diagnosis, IVUS is the gold standard. It may pick up even undetected hematomas which are not seen usually on the angiography. So why should it be treated? Nowadays we plan the strategy, hybrid PCI strategy based on the IJCTO score, and most of the advanced scores, they require antegrade dissection re-entry as one of the mechanism of opening the CTOs, and ADR is commonly utilized often as an upfront strategy, especially for higher scores. It is highly efficient method. However, it is subject to unique challenges such as failure to enter the subintimal space or failure to re-enter into the distal true lumen after subintimal guide wire crossing. So compression of the distal true lumen is a common failure mode of all the techniques of antegrade recanalization. Failure of CTO PCI is associated with worse short-term as well as long-term outcomes. To quote few of the meta-analysis and the systematic reviews, if the CTO PCI is failed, it has implications in short-term as well as long-term. With the successful CTO PCIs,
there is lower long-term all-cause mortality, lower risk of myocardial infarction, lower risk of MACE, as well as less incidence of subsequent coronary bypass artery grafting, which is seen in this meta-analysis which was published in 2017. And also there is a large series published which shows there is a mortality difference between the two groups, as well as difference in the requirement of CABG at the end of 2 years. So we should be able to manage subintimal hematomas if they occur while doing the ADR. How to manage? So prevention is the best treatment. It is the key. There is no clear consensus at present to exactly how to manage. Treatment should be individualized based on the characteristics and the re-entry points. Smith et al. Have described straw for hematoma. So for prevention, meticulous wire control is important. Small diameter bends, 1 to 2 millimeter at wire tip should be given instead of the big one or the longer one. Limit re-attempts of re-entry. Use of trapping balloon in guide catheter for microcatheter exchange, and avoiding antegrade injections. These are the few key points to help prevent formation of a subintimal hematoma while doing the antegrade dissection and re-entry. This is one example of shaping the wire less than 1 or 2 millimeters. So subintimal transcatheter withdrawal of hematoma, which was described by Smith et al. In 2015. This is a typical stingray balloon catheter inside the subintimal space, and because of the injury and some seepage of the blood, there is a subintimal hematoma formation which is occluding the distal true lumen, and this makes difficult for re-entry. So what they did was they used over the wire balloon and inflated before the CTO, before the dissected segment, and inflated 1:1 to the vessel diameter, and started aspirating the blood which was accumulated in the subintimal space. So this helped them manage this case of subintimal hematoma successfully. So they describe it as subintimal transcatheter withdrawal of the hematoma. May rescue antegrade attempts of recanalization complicated by large hematomas. Only solution, if there is no retrograde approach possible in a particular case, requires an inflated over-the-wire balloon to block inflow while aspirating distally. Nonetheless, it is a complex procedure. It needs larger bore sizes of the guiding cath, maybe 8 French. Experience and availability of wide range of devices is required. Catheter requirement sometimes goes up to 9 French also. So this is how they typically described it. This is the case which they highlighted in their case report. This is the RCA CTO where they tried crossing with a wire. The crossboss entry was failed, so they had to inflate with a balloon, create a false passage, and they took the crossboss. After taking this, they noticed the vessel lumen is collapsed, which was visible here. It is not visible up to the crux. So this was subintimal hematoma. The retrograde was not easy for this patient because it was a post-bypass case with the graft to the diagonal and LED flowing from the diagonal, and through the septals there were collaterals. So what they did, they changed the crossboss and kept a over-the-wire balloon, inflated it and aspirated 1 to 2 ml of blood, which opened up the distal lumen again. Then they changed it to a stingray balloon catheter, but again with the monorail balloon here, it did not help. Again the subintimal hematoma increased, probably because of the seepage of the blood, and then they have to put again a OTW balloon, continue aspirating the blood which was accumulated, and finally they could get the distal true lumen and completed the procedure. So alternatively, one can move the planned re-entry point distally if we are not able to do with the straw method, by using the star technique or by advancing the stingray balloon itself distally, which is called bobsledding technique. However, both of these techniques can be risky because they may create very long dissections, and studies have shown it may lead to unpredictable final result, as well as long-term outcomes are not so good. When straw fails to rescue, people have went ahead with retrograde technique. So whenever we are planning for antegrade ADR, because of subintimal hematoma, if we are not able to manage, we should be ready for the retrograde also. So subintimal hematoma should not preclude the retrograde approach. Utilize the subintimal transcatheter withdrawal technique to reduce the size of subintimal hematoma and attempt re-entry. if it is not happening, then instead of wasting the time and excess dose of radiation and contrast, we can switch from antegrade to retrograde approach if it is possible, and it should be done timely. So to conclude, prevention is the key to avoid the complication of subintimal hematoma in ADR. IVUS is the gold standard for diagnosis at present. STRO can be of great help, and it necessitates the use of 8F or 9F guide catheters. CTO PCI armamentarium should be up to date. We should be ready for antegrade and simultaneously, if need arises, and revise the plan to retrograde CTO PCI also. Thank you.
That was a really good talk, and I think you kind of hit the highlights, the keys to prevent subintimal hematoma to the maximum extent possible, and then when you do have it, which you will inevitably, I think STRA is a great strategy that you can use to reduce hematoma. Sometimes you might have to do a blind stick as well, but I think you did a good job in kind of summarizing the whole thing. Any other comments or questions? Thank you. In the interest of time, we'll invite Dr. Nasu.
Thank you very much. So my topic is undergrade and middle-grade knuckle wiring, but I already mentioned in live demo yesterday. Basically, I don't like the knuckle wire technique because it cannot be controlled by the operator. I'm not a hybrid operator. That's why my indication the knuckle wire is very limited. And also, I think the knuckle wire can make big subintimal space more easily than the wire-based tracking. And the knuckle wire-based technique cannot be recognized all the CTO. And also, the final one is very important. I want to say it to the younger physician. If you only rely on the knuckle wire technique, you miss an opportunity to learn on a guide wiring. So that's why it's basically the wire-based technique is very important to get the high success rate, so that maybe you learn from the old to these 2 days live demos. So of course, the CTO PCI requiring sometimes knuckle wire technique require knuckle wiring. So one is a long CTO. So this is a RCA CTO, but originally you can see some branches there. So but after failure of the first attempt in the articulated approach, this is the control shot of the second attempt. The length is longer than before. And also this is the chip injection of the cannabis with the distal cap of the CTO. The distal cap is also no stump. So this case is more than 8 years ago. I started from the primary knuckle wire technique with the Pyro 200. So fortunately, this case is both wire is advanced smoothly. So I could recognize the CTO, but I lose the old side branch inside in the CTO segment. So yeah, sometimes this kind of the procedure is acceptable, and also there is no way without knuckle wiring for recognize the CTO, but I don't want to sacrifice the side branch as possible I can nowadays. So, and also the torture CTO sometimes the knuckle wire have safe to trace the vessel course like this, but in some case the knuckle wire go into the subintimal space and making the shortcut in the subintimal space like this, and stretching the vessel. After recognizing the CTO, if you put the stent like this, sometimes you made a very big stent perforation after stenting. So this case is RC CTO. So actually, there is severe bending portion is there with clarification, you can see. So at that times, so of course I tried to knuckle wire, so, but the knuckle wire that didn't work well because of the clarification. So this kind of the situation, the polymer jacket wire shown black or the pilot 50 or something, can trace the CTO site like this. But this case is very hard region. After externalization, is any balloon cannot be dilated. You need to the load ablation is here, and this is the final result. So in the tortuous region is sometimes, of course, is a knuckle wire technique is very work well. So, but if you meet this kind of situation, the Sion block you can try. In some situations, Sion block work very well to trace the vessel. And the final one is in the retrograde approach. When the undergrade wire in subintima and the retrograde wire is in intima, this kind of the situation is a complete reverse cut is most difficult. So when we meet this kind of the situation, firstly the way we try to the direct wire crossing with harder wire. Sometimes we try to the reverse cut by very big burden, but it doesn't work well usually. So then, and the knuckle wire in this situation is sometimes good. So I showed one case. This is also the RCA CTO. You can see some epicollateral is there. So the undergrade wiring has been failed. So I used the direct communication from the distal LED. Yes, this is a chip injection. You can see that some channel is a proximal side from the retrograde chip injection. So I started from the retrograde guide wiring, and also I advanced the undergrade wire to complete the reverse card and check the IBUS. So IBUS show us is the retrograde wire is in intima, but undergrade IBUS is completely in the subintima space. So I try to direct wire crossing with next guy, next 1, 2, 3, and finally I use the Conquest 12 gram, but has been failed. Then I try to knuckle wiring with Pilot 200 to make it a crack between the undergrade subintima and in intima. So after making a crack, check the IBUS. This is Pilot 200 knuckle. So the knuckle wire is come to subintima from the distal to lumen like this. So this is the finally after small balloon dilatation, I completed the reverse card. So this is the schema of my procedure. On pushing the knuckle wire, the knuckle wire can make it a crack from the intima to the subintimal space around like this. So when the undergrade wire is subintima and retrograde wire is in intima, this is the most difficult situation in a retrograde approach. So, and direct wire crossing is the first choice, of course. And but the undergrade balloon from subintima usually doesn't work well. So knuckle wiring with medium weight wire, I usually use the Pilot 200, can be useful sometimes. Thank you for your attention.
Thank you very much, Dr. Nasu. That was a wonderful talk on knuckling wires. Are there any questions from the audience? The one point I'd like to make is that different wires, any wire can be knuckled. Different wires form different sized knuckles. If you knuckle an XT, oftentimes it's a lot smaller than a Pilot 200. But sometimes you need the force of the Pilot 200, which can go sometimes when XT doesn't. I usually start off with the smallest, like with the softest wire, like typically an XT, which forms a smaller, tighter knuckle, and then upsize to, like, it's kind of like upping your game a little bit, and then to the Pilot. Again, the pros and cons to knuckling, but I think many times, as they showed in long lesions or tortuous vessels, or sometimes really calcified vessels where you can't penetrate it, knuckling can be a useful tool. I think it's important to know it, and thank you again.
Okay, thank
Wonderful.
you very much.
I guess there's one question.
Yes, usually we need to the backup force for even though the advancement of knuckle wire. I usually use the microcatheter for advancement in knuckle wire.
Thank you very much, It's a Kenyan answer. May I invite Dr. R. Shiv Kumar to talk?
Yeah, respected chairpersons and friends, my talk is on Renzovo technique. If you look at the CTO algorithm, if the proximal cap is ambiguous and CTO path is ambiguous, when the CTO path is tortuous, calcified, when there is a poor distal target, upfront you start with the retrograde technique, and in retrograde, the most commonest way you progress with the retrograde wire is reverse cut. But there are some shortcomings with the reverse cut in the sense it takes your procedural time long, more contrast and more radiation. And if it is an RCA, if you do an aggressive reverse cut, you end up in stenting up to the ostium. If it is on the left side, you have to be very careful. You cannot do an aggressive reverse cut if there is a dominant big circle coming. So there are issues with the reverse cut, and worst thing with the reverse cut is it is always a subintimal tracking. So here comes a technique where there are ways it is helping us to wire in a retrograde method, but it helps you to wire in a true-to-true manner. We listened to all this reverse cut we saw in all these 2 days, and some knuckle wire all we saw just now. And regarding this Renzovo's technique, the literal meaning of Renzovo is to meet the unique meet. That means the two people are meeting where it is difficult to make them to meet. Meeting of two microcatheters and exchange of wire is a principle of technique, and it enables true-to-true lumen crossing in some cases. And another interesting is you may not end up to finish the case with externalization. There are 3 ways it can be done. One is extracoronary Renzovo, another is intracoronary, and the latest one is modified Renzovo. This extracoronary Renzovo was reported by Kim in the year well before, and you can see now there is an LED CTO, and you can see a septal from the RCA, and at the distal end there is a bend. The retrograde wire could cross. As it was ending up in the bend, they were not able to subsequently wire the distal LED. So what they did was, they did a extra coronary Renzovo in the guide catheter, relatively in a straight portion, by threading the retrograde microcatheter into the antegrade wire, now bringing the another microcatheter and meeting them both, and now bringing the antegrade wire, taking it to the septal, then withdrawing the catheter from the septal. They pulled it slowly and they just dropped it to the distal LED. Maybe at this juncture a Crusade dual lumen catheter can do this job, but here they were able to cross the wire only with retrograde technique. So the extra coronary Renzovo really helped them to subsequently get into the distal LED. So antegrade wire passing difficulty and retrograde having crossed the CTO, the usual technique is to cross retrograde can be used in large dissections and unstable wire positioning also. You can apply this technique, and it well avoids RG3 wire. This is an intracoronary reservoir which was proposed by Yamamoto, and this is a case of an RCA CTO collateralized by LAD collateral, and they brought both the antegrade microcatheter and retrograde microcatheter. They made it to meet the reservoir was happening in the intracoronary in the CTO path, and you can do it either way. Either you can take the antegrade wire to the retrograde catheter or retrograde wire to the antegrade catheter. If you take antegrade wire to the retrograde catheter, then you don't need an externalization, all that. If you take a retrograde to the antegrade, then of course you have to finish it up with externalization. And this is how it is done. They have done an antegrade to retrograde so they could avoid externalization, and they have finished the case. This is one comparison against reverse cut. This comparison between as led to the earlier CTO PCIs, where in the earlier time the reverse cut percentage was more, and when they applied this reservoir technique to replace reverse cut, the percentage of reverse cut was coming down, and more than that, there was comparison which is telling now, compared to reverse cut, reservoir can have less die use, less procedural time. It's a 2-to-2 lumen cross. So one should think of this technique either as a default strategy or as a planned strategy, either outside the coronary within the shaft guide or within the coronary in the CTO path where two catheters meet. And there is the latest modification in this reservoir. This is by Constantine, proposed in 2016, where instead of antegrade microcatheter, you bring in a guide extension catheter. Within the guide extension catheter, the retrograde wire is now trapped with the balloon, and microcatheter is taken to the guide extension. This guide extension can anywhere from the guide to the coronary instead of another microcatheter can. So they are basically meeting of either two wires or two microcatheters or one microcatheter and one guide extension. All this meeting is called as Renzover technique, and it is, I think, by practicing this technique, to conclude, intracoronary Renzovers is good alternative to reverse cut, where 2-to-2 lumen crossing with the Gaia wire and microcatheter and various modifications of the principle will enable us to complete crossing the wire and microcatheter effectively. Thank you, Anando.
Very clear demonstration of Renzover technique, and I am very highlighted. Actually, I didn't know about this technique. First time I am hearing and seeing and listening, but I didn't see any of the live cases being done with the Renzover technique. I would have been much highlighted.
I heard, I came only today, I heard from my fellows that yesterday some intracoronary
Maybe I
Renzo
have
was-
missed, yeah,
Yeah.
probably. So, probably
No?
you should tell us that how to anticipate this technique when we see any
I think from the beginning what I can suspect is you cannot plan reservoir as a planned reservoir. It will happen by chance. There are situations where you cannot externalize the retrograde wire for some reasons there, where you can make two catheters approximate and wire it. So by intention, if there is a non-availability of RG3 wire, maybe if you are antegrade, you started the case antegrade and you progress as well,